I would like to invite the moderator for the next scientific session, Dr. Anita Kumari ma'am. Ma'am completed her undergraduation and post-graduation from Madras Dental College, Chennai. Ma'am is currently working as professor in the Department of Conservative Dentistry and Endodontics, BS Dental College and Hospital, Bangalore, with teaching experience of 22 years. She is currently the assessor for NADH and had 35 publications in national and international index journal to her credit. We welcome you, ma'am.
Thank you. Anita, you can introduce the speaker. Yes, you can go ahead.
Yeah. Very good morning, everyone. It is my pleasure to introduce the guest for today, Dr. Arun Suraj, a young, dynamic cosmetic dentist and an entrepreneur. Dr. Arun Suraj is the director of Dr. Arun's 32 Pulse Dental Center, and he is a visiting professor at Sri Balaji Dental College, and he is passionate about aesthetic dentistry. He has his own copyright technique, Arun Start technique, which is a customized composite veneer technique to replicate the true anatomy of tooth. And Dr. Arun is also a course mentor of Aesthetics Melange, which is a training program designed for the clinicians in India and Dubai. This aims at teaching the porcelain veneers, anterior composites, dental photography, and digital smile design. He has Aesthetic Practice of the Year 2019 and Outstanding Dentist of the Year 2021. Dr. Arun, we request you to begin your session, and I'm also waiting to learn the Arun Stars technique. Dr. Arun, over to Dr. Arun, you can begin the session.
Good morning. Can I, am I?
Yes, you are audible.
Thank you so much for the nice introduction, ma'am. A very good morning to one and all at this conference. It's a great honor to be a part of this conference. And I would like to thank Mahalakshmi ma'am for giving me this opportunity. Though I've not interacted much with you, ma'am, but I've heard a lot about your administration and teaching skills. And it's most of your students have always been proud to say that they're a student of Dr. Mahalakshmi ma'am rather than saying they're from a college. You know, so that shows how you've branded yourself. So, and also I should thank the organizing committee, especially Rajkumar sir, Vidya madam, Kavita ma'am, Ravi Kumar sir, and one and all, each and everyone who are part of this conference. So, shall I start sharing my slide?
Yes.
So my topic is about conservative aesthetic dentistry. And as you all know, I'm a conservative dentist and an endodontist. I prefer to be known as a conservative dentist and then an endodontist when it is really in need. So I would like to start with a small disclaimer, which says this presentation does not have any product promotion involved. All the materials used and cases done are my own personal preferences and done by me respectively, based on a strong literature background. All the pictures displayed are presented and photographed by me, and I also do not reveal the facial identity of my clients who have not given me a consent. And the content for today is going to be about digital smile design, mock-up for patient acceptance. We're going to see about mock-up for test drive. We're going to see something about APT, which is aesthetic pre-evaluative temporaries, immediate dentin sealing, which is commonly known as IDS, diastema closures with composites and porcelain veneers, polychromatic layering technique, biomimetic post-endo management. You'll see a little bit of non-vital bleaching, deep caries management in the aesthetic zone, shade selection, and finally, let's check the balance between porcelain and composites. So before I start, I just want to share a short journey of how I involve much into aesthetic dentistry. I've said this in many forums and webinars, but so I'll try to make it short because we don't have much of time. So the thing is, just like any intern or any undergraduate, like especially guys, even I wanted to be an oral surgeon, because whenever we see that little blood in our gloves, that gives you a feel that you're a surgeon, you're a doctor, or makes you feel more valuable. I had the same intention, but over a period of time, when this happened when I started working in a clinic, when I was handling things all on my own. I had to treat a patient, a girl who had multiple caries on her anterior teeth, who was not even smiling. She did not even open her mouth to speak. So a person like that, and when I treated her with whatever knowledge I had those days, being an intern, all I could do is do some composite work and just mask those caries and just send her back. So over a period of time, like that was within a month or two, the same patient comes back to the clinic and meets me. And she was all in tears, and she had to say how what she went through all these years. She had a son who was 5-year-old. Her husband was not really close with her. She didn't have any social friends around, not much of socializing. So a personality like that, she started telling me over just 2 or 3 months, her whole life has been changed. And the moment she said I was the reason for changing her life, I decided I should become an aesthetic dentist, and I should start creating smiles. And I would always love when patients say that you are the reason for me to smile. So that's when my journey started, and I worked a lot on this restorative dentistry and aesthetic especially. And of course, every dentist wants to be called as a cosmetic dentist. Like if you see an orthodontist, a prosthodontist, periodontist, everyone calls themselves a aesthetic dentist. But it's all about, what I realized is anyone can be an aesthetic dentist, provided we minimally invade a tooth structure, is what I believe in. Because giving beautiful aesthetics by compromising on a lot of vital tooth structure is pretty easy. So you can destruct a lot of tooth structure, put on crowns, make it look beautiful, but for how long is the question. So I would not say that I have not done this. Even I've done this during my initial days, but later on I realized that this wasn't the right way of doing. So I started seeing, I started learning, I started reading textbooks which actually showed that porcelain veneers or minimally invasive techniques were the reason for successful aesthetic restorative dentistry. And if you ask any dentist around, how would you want your tooth to be prepared? Obviously, anyone would say that they want it the way it is done on the right side. Right. So the same thing. Imagine any dentist, they want a treatment for themselves. For example, if they wanted to correct some cosmetic treatment or some small restoration, they always prefer to go to a conservative dentist, because they believe that a conservative dentist can always be conservative on their tooth. And why not have the same intention over your patient is my question. So if you start thinking that way, because patients also are much aware nowadays. Any patients you see, they really they're Googling nowadays, they go across many websites, and they know how it has to be treated. They always feel that minimally invasive is the better way to go. So it's high time we also incorporate this into our practice. So talking about conservative aesthetic dentistry, which I strongly believe is a combination of biology, function, and aesthetics. So in other terms, it's known as biomimetic dentistry. Okay, so bio means biology, mimetic means mimicking. So what we call is mimicking biology. And as we all know, the most common materials that are available is porcelain veneers and composites. As the biomimetic dentistry principles say that small defects can be restored with composites and larger defects has to be restored with porcelain veneers. So now looking at this, I'm going to just run through a few of my cases. Initially, we'll go through some of my composite cases and then to porcelain veneers. If you see this case, it's a class for angle fracture. And now if I have to treat this, the first thing I would do is take an impression, do a wax up on the model. And in this wax up, you can almost take care of all the functions, functional interferences, everything can be done on the wax up itself. Then you can take a putty index only of the palatal aspect and then use this as a control to build your restoration. So the very important thing is your infinite bevel. If I have to give an infinite bevel, I can even mask the line of demarcation that you usually see on your class for fractures. So if you see, first thing is you can use a yellow ring burr, just slightly bevel it, round off the sharp angles, then use you make a longer bevel and then use a disc to blend that finish line. Make sure that the finish line is not visible at all. That's how you create an invisible bevel. And after that, using a putty index, you can build up the palatal shelf. And once the palatal shelf is built up, you can add your dentin, deep dentin layer, followed by a dentin, and then finally your enamel layer. Once it is finished and polished, you get a restoration that is as glossy and as realistic as you see on the image on the screen. So you can almost restore the lost structure back. So now another case which I'm going to show you is about diastema closure with composites. If you see, if you understand that diastemas with less than 3 millimeter, it's better to treat with composites. If you have diastemas that are more than 3 millimeter, it's better to do ortho or porcelain laminates. I always give porcelain laminate as an option to my patients because one thing we all have to understand is any correction of diastema with ortho always has a relapse. Based on literature, they say it is 100% relapse with orthodontics, and you have to put your patients on a lifetime fixed lingual retain. And if you imagine, if you tell this to your patients, most of them will not agree for it. Okay, so the only option is, most of us do is we don't tell our patients and we give them a shock towards the end of the treatment. Ideally, what I would say is you can also give an option of porcelain laminates or composites, depending on the case, so that you don't need a lifetime fixed lingual retainer and maintenance of maintenance over a period of time is also not difficult for the patient. So now to look at this case, if you will see a diastema, a small diastema. She's an aged patient, but still remember, even people after this social media and the Instagram and all these things, even people above 65, 70 also want to look good. They also want to have these aesthetic corrections done. That's pretty common that we see in our practices nowadays. Now she's come for a small diastema closure, and if you see this, this is the space that is present in between. What I prefer is a impression, do a wax up, so that I get a good control over the width and dimensions of my restoration. Even though we have BioClear and new matrix system that's available right now, and to make things simpler, I always believe a wax mock-up and a putty index helps in getting you that that orientation of your cant and the midline placement much precise. So I always still believe on making this putty index, and you can transfer this into the patient's mouth and create the palatal shelf. And at this stage, you can create the interdental contact points, make it fine enough, and then add just complete it with just one single monoshade composite. You can finish off the gap, close this diastema, and you can see this is how it is. Once you finish and polish it really well, you get a gloss and a shine on this. And I always believe, to bevel a little bit, even if it's a diastema closure, and I prefer using a composite brush, which helps in sculpting your composite nicely and blend it towards the bevel. This is the finish you see after the polish. That is how it was, and this is how it is. So a very remarkable change on her smile. And if you see this, I believe in papilla compression technique for all your diastema closures. Remember that rubber dam placement is very, very important with aesthetic dentistry. Not only with aesthetic dentistry, with any restorative therapy, I believe you need to learn the art of rubber dam placement. And especially for diastema closures, we see this. I will show you a technique called as a papilla compression technique with a dam. So if you have, I have this case which reports with a broken composite restoration, which I had to redo it. And once you remove the composites, I place a dam. And with this dam, if you can see, I can compress the papilla to the maximum and now I have more room to layer my composite. Okay, so I can blend my composite with my restoration, not only free of moisture, it also helps me to sculpt my composite, finish them, and you can see how well I can layer my composite. I have all the time to, smoothen the margins. And once it's finished, you can see how well the papilla is adapted to the restoration. During the, when you have the dam on itself, you can finish up the margins. You can smoothen the margins with the number. What I do is I use the number 12 BP blade sometimes, and also I use a diastrip to finish and polish, finish and smoothen below the contact point after the restoration, and then finish it. So you can see how well the papilla is blended. You don't see any erythema or any black triangle after these restorations. And once your composite is polished and smoothened really well, you get this gloss, and this is definitely going to stay for a very, very long time. Another case, which is an incisal edge fracture. This might looks very, very simple, but if you see, these incisal edge fractures are pretty complicated because they are at the incisal edge where there is a lot of enamel and dentin shades present. Okay, and if you see, because this is always visible when the patient smiles. And this is the case which reports with which he had a history of orthodontics done, a lot of remaining composites is unpolished. So I decided to restore them. So I've done a wax up, as I said, a wax up and index made. I transfer this index to the patient's mouth. Before that, I etch, I apply an adhesive, I transfer the putty index, I layer the palatal shelf, followed by layering the dentin. And you can see I placed the rim of dentin on the incisal edge. And this will help me to give that effect, create that effect. So now when the dentin is not, the layer is not polymerized, I can create these indentations. And to create that opalescence, I can even tint or stain in between, make it look more realistic, and then add the final layer on top of that. So now when I finish and polish it, I prefer to use an enhanced cone for the finishing, and finally I polish it with a goat hair wheel. And once it's done, you can see a beautiful mirror-like shiny glossy surface, and you can also see that the opalescence is well recreated at the incisal edge. So this is how it was, and this is how it is. I didn't do anything. I just worked only on the incisal edges, and that's the drastic change that we see. And if you see his smile, you can see the transformation that is present in its beautiful trans that has been visible, and it's almost realistic when compared to the laterals as well. And these kind of cases, if you see, when you're working with more of enamel and less of dentin shades, the incisal edge has to be properly planned, because most of it will be, it might be pretty weaker. So make sure your case selection is good. You should have an excessive amount of clearance. And I make sure that, I can etch almost the palatal surface so that I can grab a lot of enamel from the palatal side. So this is how he is post restoration. Now, another case where I'm going to show you how we create Macmulons. Now, if you have this chipped off teeth or a young girl, and now when I have to replicate the adjacent tooth, it's pretty challenging. So what we do is, once we create the palatal shelf, there is a lot of layering that has to be done in it. It needs a lot of, a lot of shades that has been playing the role. Now, if you see, I have dentin shades there. I have an enamel shade at the base. I have an opaque dentin on this. I have a little bit of tints in between. I have placed blue color tints in this case. I have a dentin shade as well. So when you can also create that indentations of the Macmulons and then apply, polymerize it, and then go with the final layer of enamel. And once you sculpt it, and when you finish and polish it, you will see a restoration which is almost near to that of nature. I'm sure we cannot recreate nature, but at least we can stand to an extent next to it. And this is the preoperative status, and this is the postoperative status. Now, another incisal effect on lateral incisors, if you see another similar case, which I have to build up this lateral incisor. I built it up within this shade. There are a lot of shades that are playing the role. You can see the incisal edge having a dentin shade on the rim, and I have an opaque dentin at the body surface. And then I've created the Macmulons, I've tinted in between, and almost trying to recreate the natural tooth adjacently. And then the final enamel layer. And then finished and polished. You can see how well the appearance is created. This is an immediate post-op after the polishing. And you can see the papilla is still receded. And then we call the patient after a few days, and you can see how well the papilla is blending to it. And this is how the incisal effects are visible. Now, a case to manage deep class 3 restorations. So in these kind of cases, which is pretty deep, what I believe is, you can excavate the caries, and then finally apply a Terracal LC. That is a 4th generation resin-based flowable composite. It's a calcium silicate material actually, but I prefer this more over calcium hydroxide because Terracal is known to be much better in creating the dentinal bridge, and much known to be having a much long-lasting dentinal bridge when compared to calcium hydroxide. So this is a self-adhesive restorative material. It just has to be flowed over it. You just need a little bit of moist dentin over there. You don't need to etch or apply an adhesive. You can directly apply it. As I said, it's a self-adhesive material. And over that you can etch, and over that you can apply your universal bond or your adhesive, and then layer your composite on top of that. So this is already a white opaque material. So all you have to do is just mask this material with a dentin, with an opaque dentin shade, followed by a dentin shade, and then with your enamel shade, and you will get a beautiful restoration like that. So this is an immediate post-op, and this is how it was, and this is how it is. So the advantage of this, I prefer to use this Terracal LC in most of my aesthetic deep caries management cases. And it's doing really great. So by this, I come to the end of my composite series. So I just want to say this: if you can't do great things, do small things in great way. Nowadays, patients really appreciate the smaller work that we do compared to even the greater things that you do in your practice. If you can just document these cases, send it to your patient. They really feel really good. They feel good about it. And it's not that I see a lot of general practitioners who tell me that, how can you charge so much for composites? I would say you can charge so much. Document and send the patient. Make them realize that you have done a lot of work on it. So none of my patients have complained, of me charging more. So coming to this next series, where I'm going to talk about the same biomimetic principle with restoring larger defects using porcelain veneers. And now, why porcelain veneers is a question many people ask since many ages, because we've seen a lot of failures. And when you look into literatures, you would see a very high success rate for porcelain veneers. This was back in the year 94 to 2005, where you see 95% of success rate, an average of 93-94% of success rate. And imagine now, after the recent advent of a lot of adhesive dentistry and a lot of adhesive materials, the success rate of porcelain veneers have gone even much higher. So it's all about how you prepare, how you bond. So if you are an undergraduate or a postgraduate, I would strongly recommend you to read the textbook of Pascal Magnet and US Belser, which is known as Bonded Porcelain Restoration, and also Gallup Grill's Porcelain Laminate Veneer. These 2 textbooks are enough if you change your level of practice, you're thinking about how to do dentistry. It's a real game changer in your life. It will be a game changer in your life. And looking into this is what you come to understand, that a very limited preparation, a very, very limited preparation, a very limited intraenamel preparation is enough. And all you need is a very delicate, thin restorative material to bond on it and give you that aesthetics like never before. So it is very well known that enamel is the reason for your prolonged success in adhesive dentistry. As you know, the thing is you have to understand how much the anatomy of your enamel so that you restrict your preparation within your enamel. That is, you should know that within at the gingival third, you have a 0.3 to 0.5 millimeter of enamel thickness. Middle third, you have 0.6 to 1 millimeter. Incisal third, you have 1 to 2 millimeter of enamel thickness. So that you limit your preparation within this zone, you will be able to have a very retentive restoration and a long-lasting restoration. And if you see the success rate of porcelain veneers, when it's bonded on enamel, it is 95%. So when it's bonded on dentin, it is 68%, pretty less. But nowadays, if you see the recent studies, it is shown to have an improved success rate over dentin as well. We're going to talk about that within some time. So before that, talk about digital mock-up. So now we're talking about porcelain veneers. Now, first thing that comes in our mind is, oh, it's an expensive treatment. How am I going to convince my patient? There are a lot of convincing tools. So for example, you have a patient like this. She wants a smile makeover. She's not happy with the smile. Obviously, she has a broken bridge on the right side and discolored teeth. She's got a crossbite on the left side. Obviously, it's going to be a pretty bigger treatment, and definitely it's going to be slightly more time consuming. So now I have to convince this patient. How am I going to make sure that this patient is going to accept my treatment? So if you look at this beautiful clinic setup, okay, found this on Google. It's really eye-catching, and imagine that anybody sees this, they would love to, have a clinic like this, have a setup like this. Only later I realized that this was just a 3D virtual design setup. Okay, these are done by or created by interior designers. Nowadays, you go to any interior designer, ask him for a setup that for a work to be done. He will design it so well that it will look more realistic, and anyone is going to accept it. So why not use this in dentistry? It's very simple. We have a lot of templates which you can use. You have digital templates which are in oval shape. So you can try oval shape on the patient. You can also try triangular shapes on the patient. Ask the patient which they like. If you show this from a distance, I'm trying to block the patient's identity, so that's why I'm going very close to it. But if you show this from a distance among half of the full of the face or half of a complete profile, definitely the patient will look natural. It's going to look. It's going to help the patient understand how it's going to look towards the end. And these patients will definitely accept the treatment that you're going to try. So now see this. Now, and then once the patient accepts, I'm going to start with the treatment. Obviously, if you see, she's got a slight, palatally placed left canine. So I have to do a little bit of correction on that. And I place an acrylic temporary fixed partial denture on the right side. So now I place that so that I can bond my brackets over them. I do orthodontic treatment. I try to bring that left canine outside. And this is how the case was before orthodontics, and this is how she's after orthodontics. I brought the canine outside, and now I can prep them for my porcelain veneers. Now, very limited preparation. Everything's done. I'm just finishing this case with 5 porcelain veneers. Porcelain it is after it's bonded. I always prefer to bond them under isolation. And once they're bonded, this is how she is. And this is how the reality is. So when you're going to show a virtual setup, make sure that you're going to end up the case the same way. Otherwise, it's going to be disappointing for the patient. So another case, imagine you have a lip fall, patients who have a lip fall when they smile. And if you want to show a virtual setup on a case like this, you can still crop this lip, okay, and create a lip like this and move it up, place those templates, bring this lip, crop lip back, and design the teeth and make the patient understand how it's going to look. So this is how he is post-treatment. So this is how it was, and this is how it is after the smile correction. So now I'm going to show you a mock-up for patient's acceptance. Imagine you have a patient and he wants to know how it's going to look on him directly. So if I want to do a mock-up for patient's acceptance, I have a case like this. Let's assume he's got some diastema. I'm going to treat him either with ortho or veneers or whatever you feel like. Now I want to just convince this patient. All I will have to do is take an impression, do a wax mock-up on a model, take a putty index of this wax mock-up, pour this acrylic material inside, anything like Pro-Temp, Luxatemp or anything, just directly place it into his mouth. You don't have to etch, bond, touch the tooth, no preparation, nothing. It's just placing it on him. And then you remove the excess alone. Do not show any picture, any mirror or anything. He's not going to see anything, what is done on him. You just take pictures. Take pictures of how he's going to look, with that, and just make videos. What I do is I sometimes make videos, say, remove that old bicyclic material and send the patient back. You can just send the videos or the photos to the patient, and definitely these patients will accept it, because as we all know, we all have a left brain and a right brain, right? So your right brain is pretty colorful. It loves to enjoy. It likes to procure whatever it sees. But your left brain is very, very calculative. It always likes to analyze things before going for it. So if you show a patient a virtual setup, or if you show them how a video of how the transformation is, it is going to hit the right brain. The patient will definitely go for it. So this is the idea of digital smile design. This is how digital smile design concept was designed by Christian Coachman. And selling with digital smile design is pretty easy. You don't have to, go around showing pamphlets, giving discounts to your patients. I would say if you're a budding practitioner, very, very important thing is stop giving or promoting your business by giving discounts or sale in your practice. That's going to spoil your practice really. It's going to deteriorate dentistry as well as your practice on the long run. I would say show your work, promote your skill, and that's how you get patients. It's very, very easy nowadays because we are in a digital world. And another thing is mock up to a test drive. Now, if I have a patient who's already convinced and she's already going for the treatment, she's an actress and she's got a asymmetric, asymmetric gummy smile, you can say that. So her right side is pretty visible, her gums are pretty visible. She's not happy with that, and she wants to do some correction. And now when she comes to me, and these kind of patients don't know what's actually wrong with them. They just come and tell you that their smile is not good, but they're happy with the size of the teeth. They just want some correction. They're pretty complicated because to understand them, it's pretty difficult. So what I do is I do some kind of smile analysis. I take some pictures. Whenever you take a picture of any patient smiling, these are the left one. They always give a commissural smile, which is not enough for you to treat them. Secondly, they'll give a social smile. They try to hide their defect in their smile. They just give a very, very stern, fixed smile, which is not enough. All you need is this spontaneous smile. So you make your patients talk, you communicate, just keep clicking the pictures by placing your camera on a tripod. And at one point, they will really smile out. And that's the picture that you need for working on. So when I get this smile of this patient, now I know what to work on it. So now I'm going to do, I understood that this is an asymmetric gummy smile. I'm going to do some crown lengthening only on my right side. Just contour the gingiva more on the other sides. And this is a pretty long case where I had to do osseous recontouring, wait for a very long time. So now towards the end, before I have to deliver her final veneers, I have to do something called as a test drive, because it's pretty hard to understand these kind of patients, because when they say everything, they give it to you, but once you deliver it, finally, they would always come up with a lot of options like, doc, it should have been this way, it should have been that way. So always what I prefer to do is to give them a test drive, just like what you do when you drive a car, buy a car, you want to do a test drive, you want to see how it is, feel how it is, and then buy it, right? Same like that, why not on your smile? So what I do is I do a mock-up. Again, on this case, this is a test drive mock-up. I put it on the patient. It might look bulky. Maybe the patient may not like it now, but she's going to tell you how the final outline shape is going to be. At this point, you will understand more what the patient really wants. Every patient has a different choice. So you will understand, she might say all this, the defects on this, so that you can trim it directly intraorally till the patient accepts what they want. Then take a picture of that or take an impression of that, send it to your lab, ask him to mimic the same final mock-up. And this is how we complete the case. You can see the right side gingiva, a very small, slight little bit of pink and white display, which is very much even and satisfying for the patient. This is how she was, and this is how she is. You can deliver treatment, predictable results for the patient as they choose. Now, managing malpositioned teeth with veneers. This is a pretty complicated case. You can see there's a lot of corrections to be done. She's got a peg lateral, she's got a peg canine, I don't know what to call that, but so you can call it a pig canine. Then she's got large central incisors. She's got a small defect on the left lateral, and a pretty long case, right? You can see but her left, her canine was root canal treated. She had a small decay there, spacing, the peg lateral. Everything has to be treated in this case with just veneers. So what I planned is I need to do a digital mock-up. Now we are in a digital scenario right now. So when you can scan this case, I prefer a digital wax-up instead of doing a manual wax-up. This is something which all you need is an ExoCAD. Maybe you may not have it. You can ask your technician to do it. I asked my technician to do it. He just does this wax-up for me on the screen itself. We usually have a video call. We have sit down and talk about this case, discuss this case, and finally, once I'm convinced with it, he sends me this digital wax mock-up. And if I'm happy with the design, what I do is I print this model. I print it to a resin model, and that resin model is used. And what we do is we take a T-index of that model and transfer that smile into the patient's mouth. And this is called as your APT, aesthetic pre-valued temperature. This might look very rough because I've trimmed on top of that. Sometimes your patient may not like it. They would say that it's pretty much bulky. So, but it's all right. All the corrections that your patient says, you're going to do it intraorally on that APT till the patient finally approves the size and dimension. So once this patient has approved, okay, fine, this is the dimension that I would like to have, I freeze this. I take an impression, I take a picture. And now what I do, I will plan my preparation through this APT. So what I do, I place my depth cuts through this APT, okay, and then I put my pencil markings inside. And now when I remove my APT, that is my bicyclic mock-up, I will see areas where I don't have any burr marks coming in contact. Some areas, there are no burr marks, some areas have burr marks. So this shows me that I can, restore this, I can prep this case without any, without damaging or removing unnecessary tooth structure. Got it? So now before I do that, what I have to do is I'm going to restore my caries, especially on the lateral, and I had to do a deep caries management on the premolar, and I had to restore that premolar, followed by I'm planning a direct onlay on that premolar. So I do a preparation through my APT, and this is my final preparation. Very minimally invasive. I have a planned preparation. I have not destructed most of my enamel on this. You can see the peg lateral is not made really small. I have planned it according to that APT design. So now I scan this image, scan this preparation, send it to my lab, and I get my porcelain veneers fabricated. This is how it is. And now I'm going to bond onto my tooth. I always, as I said, I prefer isolation. I prefer a proper anterior sectional isolation before I bond these veneers. And I bond my veneers one at a time, all done. And then this is how it is. You can see we have done 1, 2, 3, 4 veneers, 1 crown, because that was a root canal treated and had very efficient enamel on that. And then finally an onlay for my premolar. And this is how it is. After a 3 days post-operative status, this is how it is. You can see how well the gingiva is blended to this porcelain. And this is the result. You will not see any other restoration that can blend so well with your gingiva. It's only the porcelain that can do. So this is how she was, and this is the result that you see below. Beautiful smile, as she expected. A very great change on her. You can also get this smile makeover done with crowns, but however, what we have done here is a biomimetic approach, a conservative approach. Okay, keeping conservative dentistry in mind, I've done a very minimal preparation. This can have a long, durable results for these patients, provided it is bonded well on her. And again, my choice of veneers would be like this. Well, usually for my light cure veneer cement, usually for my veneers, I prefer a light cure veneer cement. For my thicker restorations, thicker Emax crowns or my onlays, I prefer a self-adhesive resin cement, obviously to mask the discoloration that can happen due to the increased tertiary amines present in them. And coming to my last case, this is a case which has crowding and has orthodontics to be done and followed by veneers. So now this is a case again, severe crowding. Overlapping, palatally placed. There's a crossbite on the lateral is placed much behind her. His lower lateral is also much inside. So what I decide to do is I do plan to do my orthodontics for this case. So if you see this, it's got a lot of rotation. So I have to derotate this lateral, extract this lateral, align this canine in position. In the same way, I'm planning to do an extraction of this lateral. I plan to align these teeth and close this space. And I go ahead with orthodontics. I prefer to do orthodontics myself. Being a clinician, that's one thing I learned is I learned to do my own orthodontics because I do have an orthodontist who works for me, but still I prefer to do certain things which are cosmetically driven because I know how to control them. That's the only reason. You can always incorporate a good orthodontist in your practice to get this interdisciplinary approach done. So what I do is I do an orthodontic treatment, I close these gaps, and this is the result we get after the post-orthodontic treatment. You see almost the canine is in place of the lateral right now. I didn't want to do any arch expansion or arch. All I would have done is dental expansion so that I would have tampered the occlusion, plus it would have taken a longer time. So I tried to make it much easier by just creating a little constricted arch. And now you can see this is how it is post-orthodontic. The only compromise is the canine is in place of the lateral right now. Now what I'm going to do is, this is my post-orthodontic status. Now I'm going to do a minimally invasive preparation for porcelain veneers. All I have to do is make my canine look like a lateral. So I'm going to prep my canine, which is going to be favorable for a lateral placement. And my premolar is prepped in such a way. Also, the gingiva of the premolar is contoured in such a way that I'm going to plan it for a canine. So I've done all this, designed it. I've scanned this image, sent it to my technician, and my work is done. And this is how my restorations have arrived. I've got a canine which is simulated to a lateral incisor. Okay, and my premolar which is simulated to a canine. This is how it is after bonding, and you can see for the premolar I've done an overlap and I've covered it till the fissure of my premolar. This is my lower. Patient was not ready for porcelain veneers immediately, so I had to do some composite veneers to mask the discoloration and align it. So this is the result of the upper. This is how it was, and this is how it is. So we got a kind of, it's more like a camouflage treatment, but still a better result when on his face. You can see this is how he is before his treatment. This is how he is after his treatment. And that's a beautiful change on his face over a period of time. So, okay, so my next case is a simple case. You can just closing the small spaces with porcelain veneers. Obviously, as I already told you initially, that you can still plan ortho, whatever, but in a patient who change the shape and size of the teeth, and she wants to close these gaps and she wants an immediate result, I would always give two options. So if it's a pretty elderly patient, always prefer to give them porcelain veneers also as an option, because I always, whenever you give a patient the option of doing a lifetime fixed lingual retainer, none of them will accept it. They would prefer another option. So this is a beautiful option, which I would say, because I'm just minimally invasive on the tooth. You can see how much, very minimal tooth structure that has been shaped. And we have got four porcelain veneers pressed and layered. And this is how it is when it's placed on the tooth. Such a thin porcelain, I've bonded it over, and you can see how the thickness is controlled. It's beautifully blended, and this is the post-operative. Again, as I said, you see how well the gingiva is blending to this porcelain, and on a closer look, you can see beautiful restoration of nature. You need a skilled technician again to do these kind of things. So a very quick result within a very short time. I would have loved to involve canines as well, but the patient was convinced only for a lateral to lateral. And yes, again, it was a beautiful end for her. So this is how she is, and this is how she was, and this is how she is. So now managing spacing and mild proclination with veneers. Now, if you see a case like this, she's got a little spacing, plus she's got a slight proclination, and she's not really ready for orthodontic treatment. A case like this, so what I plan to do is, I want to bring the, reduce the overjet. At the same time, I'm just going to close the gaps. So I'm planning for, I'll also have to reduce the length of the incisors. You can see she's got, an increased length of the centrals. So obviously my prep is going to be a little aggressive in conditions like this. So if I do a preparation, I'm definitely going to expose dentin more on the incisal third of this case. So if you see this, I have a lot of dentin exposed on the incisal third. So what I plan to do is I would do something called as immediate dentin sealing, okay, or very commonly known as IDS. So what we do in this is, when your dentin is freshly cut and your collagen fibrils are still moist, the bonding, the adhesive potential is much better. So before even you take the impression, what you have to do is just blot dry it and immediately, place your adhesive over there. Most of the literature suggests OptiBond FL as the best immediate dentin sealing. They don't suggest any other material. So only OptiBond FL is known to be or proved to be the best adhesive for immediate dentin sealing. And it is known to increase the dentin bond strength. Number two, it reduces post-op hypersensitivity as well. So if you see many studies, there are many studies that shows that these immediate dentin sealing can also provide a similar or even higher microtensile bond strength when compared to a dentin enamel junction, which is up to 47 to 51 megapascal. Imagine you have a better bond strength with IDS, because with immediate dentin sealing, you're sealing more onto the your bond strength is more onto the dentin, and the bond strength through dentin will deteriorate over a period of time. So naturally, you are bound to have a pretty higher bond strength, and then when it deteriorates, so even over a period of time, you will still have a very good longevity of your restoration. So the same. And if you see this recent article which I went through, this is a 2019 article which they studied on 384 feldspathic veneers, and it was an 11-year trial. They found out it's a breakthrough, I can say, because you can even bond on 50% of dentin exposure and deliver great results. So imagine there is no option for crowns. We are slowly moving more close towards the adhesive dentistry era. And you can, and also if you see the next thing is you can even bond much well over pre-existing restorations, like you have a composite or anything. And number three, you can see the myth of saying that you cannot bond on veneers, bond on endodontic teeth is also broken. That, they say that there was no big difference in the survival rate except for the color mismatch. You can still go with a thicker porcelain or a porcelain with an opaque ingot. You can still use porcelain veneers on endodontically treated teeth. So the same, coming back to the same case. Now I've done an IDS, and I temporize this patient. I send her back, and I call her on the day of bonding. What I have to do is I've isolated, as you see on the picture, I isolated with the dam. Now the area where the IDS is done, I have to do a little bit of air abrasion. I'm going to reactivate the IDS to create a fresh bonding surface. Now, once I reactivate this IDS, after that, I can etch the tooth overall. And once you dry it, you will see the frost more on the enamel area, less frost on the IDS area. So now once it is done, I bond my veneers one at a time. And this is how it looks 2 days post-operative. A beautiful result where you can see how well, again, the porcelain is blended really well to the gingiva. This is how she is after your smile. You can see how well the proclination is reduced. You can see how well her spaces are also closed. Okay, this is how it was, and this is how it is right now. So now, smile design with crown lengthening procedures, gingival depigmentation. This is a pretty elaborate case again, followed by veneers. Now this is a case which comes to me. She also wants to get into movies and all that. Now she wants an immediate result, and she's got a pretty gummy smile, hyperpigmented gingiva, malaligned teeth, a lot of problems in her. Now what I plan to do is I'm going to do gingival depigmentation. I'm going to do a crown lengthening, a lot of work on her, make it heal, let it heal for a very long time. And finally, I've planned my porcelain veneers. I've got 8 porcelain veneers done and fabricated, bonded on her, right from premolar to premolar. And this is the result. You can see the gingiva's color is blended so well, and this is how she is after a smile. This is a life-changing smile makeover. You can see how she was before, and this is how she is. I know I'm going a little faster because we have a lack of time and I have lots to cover up. I'm going to finish it in a while. So talking about biomimetic post-endodontic restoration. If you look into post-endodontic restoration, also you can consider porcelain veneers, because it's very well known that the main reason for a failed endodontic treatment is their unsuccessful restoration. You trim down, you chop down a tooth, make it look so small, you try to bond everything on that little bit of the resilient, fragile dentin is definitely going to fracture over a period of time. As we all know, dentin will demineralize over a period after 6 years or so. So you're going to have a failure that's going to arise. So it's always better to preserve the natural, the enamel behind and try to bond something on top of it. Okay, so as you know, many studies have also proved that coronal coverage does not successfully improve the success of endodontically treated teeth. So I prefer to do avoid crowns for all my anterior cases, no matter what it is. So even if it's a discolored tooth, if you want to replicate the same texture and morphology of this of the adjacent tooth, all you can do is just do a non-vital bleaching. No, you really don't need to be invasive on this tooth by cutting them down, going for zirconia crowns, anything. You can just do a non-vital bleaching with sodium perborate mixed with distilled water, just in a 2:1 ratio. Take it in amalgam care. I save a lot of money in this because sodium perborate costs you very, very less. You don't even need opalescence boost for this. If you are really you're not able to procure sodium perborate, you can then think about opalescence boost, which is commercially available in the market. So this is a result just after non-vital bleaching, and you can see the change on this patient. So in some cases, you can also veneer, as I said, over non-vital tooth. This is a case where I severely discolored. So I do something called as a non-vital bleaching. I try to lighten the stump shape, because you see, this is a very long-standing lesion where we cannot, remove the reduce the discolorations completely. Still, it's after 3 visits, I still have a very frosty, white teeth. So now what I plan is I'm planning to bond on top of this. Now the ideal time for bonding a porcelain veneer should be definitely after 3 weeks, because we know that the oxygen is eliminated. It continuously tends to eliminate from the chamber. So you can leave for a while of 3 weeks and then plan the bonding. And once you bond, I plan to prep maximum all on enamel, and just with a single veneer, you can bond it over. And if you have a very good shade matching capabilities, you can blend it and make it look almost similar to that of the natural. This is how it is, and this is how it was, and this is how it is. Now, if you look into textbooks like for Pascal Magnet, it very clearly says that except in cases of endodontically treated teeth with severe breakdown of tooth structure, there is currently no evidence that contraindicates veneering a non-vital teeth. There are many claims that says that you can discolor over a period of time and all that, provided all I take care is that provided we do the root canal ourselves and then plan for the veneers over it. At least I always prefer to go for a thicker veneer, and also I suggest my technician to make it with a medium opacity ingot, so that even if there is a slight amount of discoloration, it is not going to be visible through the veneer. And also a thickness should not be less than 0.5 millimeters on endodontically treated teeth. So coming into the porcelain veneer and the composite balance, all you need to be clear is with the light cure unit, shade selection, success rate, preparation design. This has to be balanced, and every case selection is based on that. Light cure units, make sure you have a very good light cure unit with a higher intensity. For example, for porcelain veneers, at least you need an intensity of 1200 milliwatt per centimeter square above, and for composite, at least you need all you need is a 700 milliwatt intensity light cure unit. Shade selection, let me look into the preparation before that. Preparation, if you see the preparation design for composite layering, yes, you need to bevel, just a bevel is enough. And you can always call composite as a minimally invasive when compared to porcelain veneer, because we hardly prep on them. All you need is a bevel and you can give this restoration. But for a porcelain veneer, yes, you need to be a little more invasive when compared to composites. So it is a choice between you and your patient. So next thing is success rate. If you look at the success rate, I already told you veneers, porcelain veneers has a higher success rate on an average of 94% or even above. But however, when you look at composites, A 10-year period, they found in a meta-analysis that 95% success rate is there for a class 3 composite, but for a class 4 composite, the success rate is slightly less. It goes to 90%. And it's well known that hybrid composites were less prone to fracture, and it's very, very advisable to bevel a tooth to reduce the marginal stainings. Again, now comes to shade selection. We all know for porcelain veneers, we need a shade selection to be done with a Vita classical shade guide, but the same cannot go with your the composite. Vita classical shade guide, I always prefer to take a picture, good quality picture with your DSLR. Take it with a gray 18% gray card behind. Take the click the image, make sure the reflections that fall on the tooth and the shade tab is also even. Okay, so make sure the reflections are also not bad, and then you also have to take a stump shade using a stump shade guide which is available at Biomimetic. Make sure that the stump shade is also selected and sent to the lab. Proper pictures, good communication, you get a very good work done with your lab. Shade selection for composite is definitely different from porcelain. See, these are different A2 shades from different companies, but they all look different, because the A2 from one company does not look the same from other brand. So this is something which you have to know. And what we do is, this is a style Italian technique, which they say is a button technique. You place a small ball of composite on the tooth, take a picture, put it in your computer, and then see that. Then you understand which shade goes well. What I prefer sometimes is I use something called as a composite spread technique. I spread that button and make it more longitudinal, so that I take a picture and the reflections are almost even to that of a natural tooth. So this gives me a much predictable shade selection. And then you can also move it to increase the contrast in your image, and then check which shade goes well. And based on that, you can select your shade for your dentin. And for an enamel, always change it to a monochromatic mode, a black and white mode, and check which enamel goes well, because you determine the value of your enamel. And now, what to choose? Again, I say it's based on few factors like age. I always prefer composites for younger patients less than 20, definitely composites. Tooth position is a criteria. Economic criteria are there. Material science understanding the material science is very important. Armamentarium and operator skills. Operator skill is very, very important when you want to do composites. If you're really not confident with your operator skills, always just believe on porcelain veneers. So invest, what I would say, when you want to do great work, invest on good instruments. I prefer to use this LMR instruments from Style Italiano. They're really thin, flimsy, very, very ergonomic, and they work really well in all my composite work. And again, very, very important keys in minimally invasive dentistry: magnification and isolation. Isolation is something which I believe nowadays many colleges, they're insisting on isolation, and I'm so proud to say that most of the students from SRM Dental College always tell that my ma'am is very, very strict with isolation. So I've heard that a lot. So I'm really nice to hear that. And I always believe isolation with rubber dam is very, very important in your practice. Similarly, magnification. A little amount of magnification is very, very important to know that whether you are restricting your preparation with an enamel or dentin. Because I'm not just saying that you have to invest on a high-end microscope. At least a good loops will do to help you do a better level of practice. This is the case. And very, very important thing is, whatever smile makeover you do, you want to change beautiful smile, convert beautiful smiles, or we get so tempted to show the patient's face, right? We want to show the patient's face on media, on social media. But remember, it's not ideal, because to show any patient's face might look nice to get a lot of clicks or likes. But it's very, very important that you take a consent form from them. Make sure they sign a consent form. I make it a point that my patients sign a consent form and let me and let me know that I can reveal their facial identity. This is very, very important, because these things might be tempting for us to just show their face. But when the patient gets to know that you show their faces on social media, you will lose your practice over a period of time. Okay, so it's always better take a consent from the patient and show. If the patient does not give you, I'm sure 99% of our patients will not give a consent. If they don't give a consent, never expose at all. Okay, so that's very, very important. And We are life changers. I'm going to conclude this. As you can see, this is one of my smile makeover patients. She comes to me. She's a very ordinary housewife, very, very conservative girl. And when she comes just after a week for a photograph, she comes with, a hair color done, lipstick, her whole, appearance has changed, because I found that, we played a role, we played a role in changing her lifestyle, That's where we can be proud of. We dentists can change someone's lifestyle, and that's where dentistry is moving. People value us a lot nowadays. So finally, to conclude, the better you bond, the lesser you need retention and resistance form. Okay, the lesser you need a stronger material. The thinnest material is more than enough to deliver a beautiful aesthetics. Finally, thank you so much. Thanks a lot. I should thank especially my teachers from Sri Balaji Dental College. I'm a student from Balaji Dental College, especially my teachers like Dr. Vijay Sukumaran sir, Subaya sir, Vivekanand sir, Mensuder ma'am, Prakash sir, a lot of people who have chiseled me, sculpted me, made me a good refined dentist. And I'm so proud to be at this conference today. It's all because of them. And thank you for the wonderful opportunity, Mahalakshmi ma'am and Rajkumar sir and the complete team behind this. Thank you.
Anita, unmute yourself.
Yes. First, I would like to congratulate Dr. Arun for the fantastic photography. Oh my God, such beautiful photographs, Doctor.
Thank you,
Okay,
ma'am.
and then you did comprehensively present the entire cosmetic dentistry, beautiful anterior composite case series, then digital mock-ups, tip for successful clinical practice, and then porcelain veneers, the importance of biomimetics, and then immediate dentin sealing. It was a fantastic lecture. I'm sure you have inspired many people, many who are there in the audience. Definitely everybody must be looking into where to go join cosmetic dentistry now. Okay, that's a fantastic, you're truly an inspiration. That's a fantastic lecture, Dr. Arun.
Thank you so much.
And I would like to thank Maha ma'am, Dr. Rajkumar, Dr. Vidya, and the entire team for bringing out such an innovative and a very informative program like this. Thank you, ma'am. Thank you once again. Thank you all of you.
Arun, can you stop sharing your screen, please?
Yes, ma'am.
Yeah.
Ma'am, there are a few questions. Do I have time? There are three questions.
Yes, please.
Yeah?
Please go ahead.
Okay, ma'am. I would like to personally ask Dr. Arun, which composite do you prefer for the direct composite work?
Nice question, ma'am. Everyone asked me this question. I personally believe that it's not about the composite material. It's about understanding the layers of the composite that we have. If you can, I prefer to use a lot of brands. I prefer Dentsply, Neospectra. I prefer GCs, GNL. I prefer Shofu. These three are predominant in my practice. Sometimes, because we see in GNL, you have that high translucent enamel shade, which is not available with other brands. So when I have a case like that, I have to change the brand that I have. So I can never be brand specific in most of my cases. That's the thing that I believe. And I always believe in using composites that have that are camphor-quinone based, and most of them are there. Because we still use an LED to cure them. So that's all.
What is the prognosis for a ceramic veneer on an endodontically treated teeth compared to a vital teeth? Do you feel the prognosis differs for a non-vital over a vital?
Yes, comparatively, it might differ because, as I said, you have to restrict your preparation all on enamel when it is a non-vital tooth. But when it comes to a vital tooth, if you have exposed a little bit of dentin, still you can bond on it. You can still do an immediate dentin sealing. It works. But on a endodontically treated teeth, you should make it a point that you have all enamel and your preparation is all on enamel. That matters a lot. So in my clinical scenario, I've been reviewing all my cases. They're doing well. The only thing I could say is maybe my preparations are all on enamel. So that's very, very important because I've seen cases that fail when it is all on dentin on a non-white leaf. So that's very important.
I like the way you emphasized on interdisciplinary dentistry, the role of ortho as well as the other periodontics, and also the way you spoke on informed consent for photography. I don't know how many of them really follow, but that made a lot of difference as lecture, Arun.
Thank you.
Yes.
Thanks.
Thank you, Dr. Arun Suraj sir, for a wonderful lecture, and thank you, Dr. Anita Kumari ma'am, for moderating the session. I request Dr. Arun Suraj sir to kindly accept our token of appreciation for your intellectual output.
Thank you.
Thank you, sir. I also request Dr. Anita Kumari ma'am to kindly accept our token of appreciation for the valuable time on the inputs. Thank you, sir. Thank you, ma'am.
Can I leave?
Yes, you may. Thank you very much, Arun.
Thank you, ma'am. Thank you.
Once again, thank you,
you,
ma'am.
Doctor.
Thank you.
Thank you so much. Thank you,
Thank
ma'am.
you, Anita. Sorry for delay on your certificate. I don't know.
No, ma'am. No, ma'am. I can understand. Thank you, ma'am. Thank you so much.
Just
Bye-bye.
It's there, it's
It
there.
came. It came. It came. Thank you, ma'am. Thank you.
Thank you.
Thank you,
Bye-bye.
madam, ma'am. Thank you, Dr. Raj.
Thank you,
Bye-bye.
ma'am. Thank you.